Good morning. So we have no financial disclosures associated with this topic. So West of England Eye Unit was the first to introduce nurse practitioners to perform intravitreal injections in 2008. And initially the protocol involved ofloxacin drops 4 times a day for 5 days after injection. However, evidence for this practice is limited, and of course overuse of antibiotics is probably related to increase of resistant strains, as well as burden to the patient and to the healthcare system. That is why we decided to change the protocol, and we discontinued use of ofloxacin. Instead, started using 1 drop of chloramphenicol after injection. We designed this study to see if ofloxacin drops 4 times a day for 5 days are necessary to reduce the risk of endophthalmitis. We designed a retrospective analysis of patients undergoing anti-VEGF injections between 1st of September 2012 and 31st of March 2017. So they were divided in 2 groups, treated in 2 protocols. They both involved cleaning of lids and conjunctival sac with povidone iodine 5% drape and lid speculum, and the difference was in antibiotics used as a prophylaxis. So in ofloxacin treated group, we had 9,692 injections, out of which 2 developed. In 2 cases there was endophthalmitis giving rate of 0.02%. In chloramphenicol treated group, 9,683 injections, 1 case of endophthalmitis giving the rate of 0.01%. So in conclusion, ofloxacin prophylaxis for 5 days is not required to prevent endophthalmitis, and this can be safely omitted. This kind of approach is cost-saving for finances, as well as decreases burden to the patient, and possibly might reduce the risk of development of bacterial-resistant strains. Thank you for your attention.
Aptis Basir from Minnesota presented a multi-center study using huge numbers and showed that there is no need for antibiotic prophylaxis after intravitreal injections, period.
There are a few studies showing similar results. So even actually there is tendency towards increased risk of endophthalmitis with antibiotic prophylaxis. So in our study, it's difficult to discuss statistical significance because of the rarity of the condition, so we couldn't actually calculate any sort of statistical numbers. But from other studies, they are showing that actually stopping antibiotics not only is not affecting safety, but also seems to decrease the risk of endophthalmitis.
I have a comment on that. Was just published on Retina from the group from Catania, Italy. They reviewed 40 large studies, about 700,000 intravitreal injection on anti-VEGF, and they conclude that do the antibiotic prophylaxis increase for 3 times the risk of endophthalmitis. So the suggestion is not to do the antibiotic prophylaxis. So surprising, you think that must be the same, do it or not to do it, and do the antibiotic prophylaxis increase the risk for 3 times.
I think it's like with cataract surgery, the most important is proper antisepsis.
Barbara?
Yeah, it was to underline what he was saying. She's talking about post-op therapy. But at least in Italy, I would like to know what's done outside Italy. We used to prescribe antibiotics for 3 days before injection, before any surgery. And I personally think it doesn't make any sense, but my opinion is nothing compared to evidence. So I would like to know what is done outside Italy and what you think is the right thing to do. And one more thing, we have now new drops based on povidone iodine. Do you think it makes sense to use that before as prophylaxis?
I can actually add a comment from our experience. So that was not included in the study analysis, but for some time after changing the protocol, we were giving a drop of chloramphenicol before the injection. But we stopped doing this after a short time, and it didn't seem to change anything. And in case, answering the second part, I think that like 2-3 minutes of povidone iodine in the conjunctival sac before the injection, that is the approach. And I'm not sure if it makes sense to give it like a few days before.
Okay.
Yeah.
You know, many times common sense will guide you, and then we need sophisticated studies to just prove that our common sense was right. You close the door before someone comes into your house, not after. So the essential part is the prophylaxis when the patient comes. You use just povidone in the conjunctiva. The fact is that you have to use it long enough. So the problem with the patients that are put on a conveyor belt and they are sent for, especially in those centers where you have 40, 50 injections per day, is that the time is not sufficient. It's just a pro forma. The patient is put on the bed, they put the drop in, and then the surgeon immediately injects. That's not enough. You have to leave the antiseptic there to kill the germs. Otherwise, you're not achieving the result. As far as the antibiotics study proves, I think what you are doing by giving antibiotics before is essentially, we know that you never get 100% sterile environment. What you're doing, you're selecting more aggressive germs so that the ones that you do introduce within the eye are more aggressive. What good is it to give chloramphenicol drops or any kind of drops after when you know that the penetration within the eye will not match the aggressiveness of the pathogen you put in?
Gianpaolo, this is worse than that. It's a very crucial legal medical issue. I would really like to know if we can have guidelines or proposal, because as head of department, I propose to my colleagues to remove antibiotics before surgery. We are giving the patients prescription, officially prescription from the clinic to use antibiotics before any surgery, injection, cataract, whatever. Am I allowed to remove that that tradition? That doesn't make any sense.
I don't think there's any protocol, official protocol, that tells you that you have to use antibiotics. But if we start accumulating evidence, such as this very large study, which says that antibiotics are actually harmful, then you can take that up to court and say, these are the studies.
That's true. Great point on keep using your common sense. I think everyone will agree on that. And one very important point on the povidone iodine is that none of the bacteria will ever get resistance to povidone iodine. That's one, much better than any antibiotic. And the other point is that, like you pointed out, take your time between the drop and the surgery, but even apply povidone iodine twice, because it's been proven that it even increases the bacterial load with another 5%. And don't forget to clean the eyelids, especially now with these new in-vitro devices. When you put them in, you tend to touch the eyelids a little bit, so if the eyelids are not disinfected properly, in my opinion, you will increase the risk for endophthalmitis. Thank you.
You touched on another topic. Those devices, I think, are rather dangerous. They look great. They're easy for especially non-vitreal surgeons, because anybody can do it. Nurses, and it's just it's so easy. But as you're using them, You're dragging in everything from the eyelashes, and you never get the eyelashes completely clean. It's impossible. So you're dragging everything in, and the fact that we do not have a large number of endophthalmitis, as one would expect, is simply because the body does react. So I'm sure that you do introduce a bit of bacteria, but the body has its own defenses. So fortunately, they do defend themselves. We have, yes?
Yes, we're happy to have an immune-privileged environment in the eye compared to the general surgeons. So
yes. Can we take some more questions?
Maybe one.
Maybe one.
Thank you. I totally agree with the design of the study. However, extrapolating this result must be done with great precautions. We need to look at the population of patients who are receiving injections in Europe and the proportion of the diabetic people among them. If the bulk of your work is with AMD patients, you are supposed to have a much less risk of complications, number one. Number two, regional differences in the conjunctival flora. In the Middle East, where I practice for 22 years, we have much more predominant contamination of the fornices. We have heavy use of makeup among the female patients. We have scarring of the conjunctiva due to old trachoma, and this all is increasing completely in a different level the risk of complications in patients during even simple procedures like injections. So extrapolating must be done with great precautions. What I would think is to take samples, and we have to see the different growth of microorganisms in different regions, and then we can decide if it is, as you said, common sense to do some prophylaxis and post-injection treatment as well. Thank you.